Thank you all for coming. I'm excited to kind of get to share my portfolio of research that's been going on because I know I don't have as many opportunities doing this being a primarily teaching faculty, but innately a lot of my research is integrated with education and innovative curriculum design. A large part of that has been in relation to artificial intelligence right now, knowing that that's very much on the forefront of a lot of different industries. And so my portfolio, I think, has started to address kind of the good, so some innovative technology and examples. The bad, we're starting to kind of notice some flaws with it and how are we going to respond to that. And then also some investigations into the unknown that we need to know to contextualize how we move forward. And so starting off with the unknown, something that myself and two colleagues from external institutions, as well as two undergraduate students here at KU, but kind of diverse. We have a community health student, but also a business student. So kind of showing that interdisciplinary lens related to AI. We wanted to chart the AI policy landscape across top universities. Part of why we wanted to investigate into policy is because we recognize that AI is becoming a really substantial investment within the educational sphere. In 2019, it was projected that we would expect to exceed about an $85 million market in relation to AI in education, but that number has significantly exceeded that anticipation and projection to $7.05 billion worth of investment in AI technologies and is estimated to increase drastically in the coming years. And so with that, we wanted to see what is the landscape and what are the guidelines that we're supposed to be operating in as an institution. What's interesting, though, is AI is not necessarily novel or new to education. It was introduced in the mid-1950s. And so we wanted to start to also investigate when did we start to see upticks in its relevance to faculty, staff, and students. And we noticed some major upticks in 2012 and 2016, which was a reflection of some global initiatives going on, largely led by Google and our ability to engage as active participants. We've also noticed that it's starting to be integrated more across a wide variety of different applications within education, including all the way from predictive modeling of which students might be more successful than other groups. We also have it as a way to create adaptive learning environments for more universal design, and then teaching designs. And that tends to be where I'm more in that little bubble of teaching design. With that, though, even though we continue to invest financially and we're seeing additional implementation, there's been this continuous discourse regarding the ethical implications of AI integration in education and their respective industry fields that our students eventually leave and go into. And so what we wanted to do was the way that artificial intelligence use is being portrayed to relevant stakeholders within education spheres is really limited, though. So we wanted to investigate the top-ranking universities as defined by U.S. World News Best listings of what policy language are they using to guide this framework as we continue to go forward. And so our students were able to identify, based on that ranking, the top 10 public institutions, as well as the top 10 private institutions, because we wanted to differentiate between the two different institution types, knowing that there's different funding mechanisms and governance policies. And so from there, they went to each of these respective institutions' publicly available websites on any published policy related to artificial intelligence use on a university setting. So with that, it encompassed both faculty-directed policies, general for any kind of stakeholder on campus, and some that were student-focused. And so we didn't discriminate. We copy and pasted that exact language, knowing that it might be evolving and changing as we continue to learn more. These data collection procedures, though, were conducted in September and October of 2025. So not too old, but I recognize that this is a quickly and rapidly evolving sphere. So with that, then they did an inductive content analysis, meaning that they were identifying salient themes throughout the policy language. But in addition, because we use content analysis, we're allowed to infer meaning based on how frequent specific themes were prevalent across the different shared policies. And so the students were able to identify 6 overarching themes, one of which did have a sub-theme. I'm not going to get to go too in depth about each of these because I realize I have a couple of different studies that I want to share with you all. But the most prevalent was ethical considerations in AI use, which is we kind of predicted would be prevalent, knowing that that ethical consideration discourse has been a continued conversation across decades. Ranging all the way down to AI use governance on how we should actually be behaviorally interacting with AI was the least prevalent, but we see some pretty significant differences here in the middle between promoting innovative through AI adoption and human-centered approaches between private and public. And so just giving a couple of examples here with that most frequently cited theme of ethical considerations in AI. This was anything reflecting a shared value of ethical principle or moral guidelines to maintain fairness and academic integrity among various groups. And so we have UCLA specifically emphasizing evaluating anything that's generated from large language machines for bias and fairness to ensure that we're not perpetuating stereotypes or harmful discrimination. And then we also have some that are just by Duke University talking about the algorithms cannot always understand the context in which they're being applied to, and making sure that we have that component of mindfulness and morality. In the middle, that was pretty evenly seen, but the one theme that also had that sub-theme was safety and privacy concerns. A lot of the time we notice these, particularly among public universities, being concerned about data privacy efforts and also sensitive information that could be going out to other parties. I will tell you, University of Florida was one of these. At my time of University of Florida, if you were on UF Wi-Fi, you were not allowed to use AI because there was concerns of data breaches. And so seeing how they were manifesting that down into practice was interesting. Promoting innovation through AI adoption was a slightly different tone because it was one of the few mentions of encouragement of adoption of AI technologies to enhance both individual and organizational efficiency. This was an optimistic light and kind of tone compared to the other themes that we noticed, and this was disproportionately relevant among private institutions that were encouraging folks to engage in thoughtful environments that utilize AI to enhance skills and allow for a lens of criticality that maybe we can't just get through human engagement. And then lastly, the AI use governance. I thought this was really interesting because these were those frameworks that gave us almost kind of rules of what we should be behaving as. And Princeton University went as far as to say they feel like folks who use AI should be stating such to the recipient of that work that they are using AI. We know that that's not always happened. I don't think all of us on maybe letters of rec or emails, if we're using it, are putting at the bottom a little footnote saying AI help me generate my response. But that's essentially what they're asking folks to do through this policy language. And so some of the implications, one of them is that ethical use of AI has become the de facto foundation for higher education AI policies, which is interesting that ethics rather than technology is the primary framework in which we're trying to understand and engage with AI, especially because other things that have been technological advancements maybe have not had as severe of an ethical conversation. And so this signals that a sector-wide, meaning all education, might need to surround and have a conversation around sector-wide alignment regarding fairness, integrity, non-discrimination, and shared transparency as academic values. I bring this up because I think that's really challenging in an era when we are under an administration that is directly kind of opposing various large language machine AI, generative AI companies, saying that they do not want woke responses in algorithms, and that those who go against that kind of executive order are being found to be considered threats against national security and are being put out, such as Anthropic. So what are we defining as fair, integrity, and non-discrimination is kind of muddled currently as a society as we continue to advance in these conversations with our students. In addition, there is a wide shared uncertainty and caution around accuracy and reliability of output from AI. And so that means we may need to see AI literacy as a critical academic competency that we are now kind of the stewards of imposing on our students. And I think that that's particularly challenging when we are seeing that students' ability to gauge credibility, trustworthiness, and misinformation is largely already recorded as subpar. The example I found here was when students were asked to assess a factual report regarding climate change. 96% never identified that the author or publisher of the report was a fossil fuel industry company. 2/3 thought that ads and news stories were the same thing. And then more than half thought that an anonymous Facebook video that was shot in Russia provided strong evidence of US voter fraud. So just seeing that our students' ability to assess credibility is already kind of lower than what we would hope for, and now adding in a new lens of credibility evaluation and validity evaluation might be more challenging than we are anticipating in future years. And then the last implication based on this work thus far is that private universities seem to be more eager and excited and enthusiastic about the innovations that AI might bring, which could create a potential innovation gap and perpetuate future disparities across different groups of students depending on which institution type they're able to go to or potentially elect to go to moving forward. So something that's good though, so now we have our unknown, but something that I think that is really cool and something that we're really proud of is myself and two colleagues, so one is from University of Notre Dame, the other one's from University of Florida, have been using AI to develop virtual reality programs for global public health and global community health work. So specifically, we wanted to utilize virtual reality because in a global health course, it's really hard to simulate global practice in a classroom, right? Something that requires interaction with diverse cultures and diverse groups of people with issues that maybe they're not familiar with is really hard to simulate. And so VR creates a more immersive and engaging experiential learning opportunity for students. It also accommodates diverse learning styles, and you get to learn through that experiential learning. So the actual seeing, doing, and experiencing has been shown to be more effective, right, than a didactic, more passive consumption of information. And so my colleague from Notre Dame has kind of biannual global health trips to address relevant issues across the globe, and she got to do a project regarding chat, which is a plant largely grown and consumed that it's extremely addictive in Ethiopia. And so when she went to Ethiopia to do her grant work, she was able to wear essentially a GoPro kind of while she was doing her stakeholder interviews regarding chat and collecting data with informed consent. And we got to come back with that footage, and we worked with ND Learning, who then made it part of a 360 virtual reality experience for students who were training to be global health practitioners. And they got to be kind of what we're calling the life of a global health researcher, where they got to make several decisions on if they were interviewing a farmer, how would they dress, what kind of questions would they be specifically asking, in what order would they be asking. And then they got to get the responses that were the filmed true responses of our participants. And so part of this was part of a larger kind of model that we're trying to generate theory, saying whether or not this is truly a viable way to enhance global health competencies and cultural awareness and humility among future professionals. And so the virtual reality experience is part one, but then they also have a discussion with their peers in a classroom setting after the VR experience, where they get to compare based on an assigned stakeholder role that they had during their experience, what it was like and what are some things that they wish they could have done differently or the same. And then they get to do a summer capstone experience. And because Notre Dame is a private institution, they have a lot more money, they actually pay for their students to go abroad and do this work. So this is a guaranteed component of their master's program that they do the summer in between their year one and year two. And so the hope is that we have better prepared them for that summer capstone experience rather than if they hadn't had VR exposure. And then they concluded with a reflection paper. So we do have a nice kind of wealth of data right now. We have weekly reflection notes, we have the VR reflection papers, we have the group discussions that we audio recorded so that we could hear what were their conversations and how were they leveraging each other's experiences to further enhance their understanding. Then we have their capstone field survey, and then we also have this going on from year to year, and then in between they have their exit survey. Ultimately, without going too much into depth about this, we're hoping to leverage that virtual reality experience that creates a grounded in the theory of authenticity to enhance experiential learning that's a well-documented learning theory to better prepare these students to be qualified professionals as they progress into their careers. That being said, because we've now done that since 2023, we got some nice 2025 feedback, and we've made some revisions based on it. And so 2 cohorts had indicated they wanted some greater, more active involvement in the VR simulation. They wanted to have real-time discussions and dynamic problem solving rather than being more passive recipients of selecting just the order of questions. And so we did another proposal to ND Learning to integrate artificial intelligence to personalize scenarios and give more of that predictive response based on a character. So we had created, based off of our experience with our stakeholders in Ethiopia, some avatars. And so these are 3 of our avatars that were developed as part of the virtual reality experience now that kind of go along and talk to our students. So how do we develop an avatar? Largely, ND Learning has the people who are way smarter than I am to do all the coding and data input, but we were responsible for giving core descriptions, speaking style, sample dialogue, and personality. And so the core descriptions include what is the context in which these people are living, operating, and engaging about health discussions. What's the objective of their role in this conversation? We have to outline a situation, a task, what kind of action, what kind of response they more likely give to a person engaging regarding a chat conversation. In terms of personality, we had to give metrics on what their openness would be, meticulousness, their extroversion, agreeability, and sensitivity, just to create the different personalities that were more generalizable across that type of profession. And so here's just an example of one. We have Desta, who is an entrepreneur, but also a chat user. And so we see some of what his potential answers or responses would be regarding chat, and talking about the fact that, yes, it's addictive and causes problems, but look how productive it makes us, which was largely kind of the mindset folks had regarding chat use in this region of Ethiopia. We also, like I said, gave those numeric values to give their personality of what maybe they would be agreeable to in terms of changing behavior, but also maybe how open and extroverted they are about their specific opinions regarding chat use. One of our major challenges, though, that we are having in regards to our AI avatars is hallucinations. I don't know if you all are familiar with AI hallucinations. We are particularly challenged with the sentence contradiction and the prompt contradiction, where they try to almost predict what would be said next, where they add something that either contradicts something they previously said, goes against what we're trying to have them do, or is conflicting with the original kind of context that we had given it in. So we're having a lot of issues with hallucinations. And so we've spent a significant amount of time working with ND Learning on how to develop the correct guardrails that allow for that authentic conversation with an avatar, but not necessarily stifle their ability to do it in a factual and appropriate manner that's representative of the population we're trying to have students engage with. So guardrails has been something I've learned about that I did not anticipate learning about as much when I was engaging in this AI work. All right, and then lastly, the bad, and I put a question mark here because we don't know yet. This study is mid-study. We know from large data sets that are typically used as the algorithms for large language models, they tend to be chronicled with societal biases. We can point specifically to the internet largely being racist and homophobic from previous research, but we're curious whether or not AI technologies are reinforcing these stereotypes, especially knowing that our students are often engaging with them for coursework or for guidance and direction on maybe how to move forward. And that is also evidence not only before college, but we are seeing that almost increase from 79 to 84% of high school students reported using some form of generative AI between January and May of last year, and that approximately 85% of college students said that they have used generative AI for their coursework within the last academic year. So we know that this is a problem, that they are engaging in it, and so to not kind of do more of like a harm reduction approach of saying, but how is it reinforcing or potentially dismantling biases is important. And so our focus, because we, as in my colleagues that are at Notre Dame in Florida and myself, are all health and community health related, we know that pre-health students will be eventually expected to engage with diverse audience and diverse populations through patient experience or community outreach that deserve equitable treatment. And so we want to see whether or not these stereotypes and biases are being perpetuated through generative AI use or not. And so right now we're doing a randomized controlled trial study design where students from all 3 institutions are invited to participate. They are then randomized into one of 3 arms. Arm 1 means that they get to use AI and give it feedback through liking or having conversation. Arm 2 is no interactive, meaning they get to use AI, but then they can't at any point engage with it. Their initial response or prompt, or they have to clear their cookies, is the only time they get to input. And then lastly, it's a student-generated essay response, no AI assistance, to a somewhat controversial health-related prompt. And so we want to see how their responses are potentially different and maybe reinforcing or maybe not reinforcing these biases that we know the internet has. And so right now, like I said, we are in the middle of recruiting and doing that project, and so this has been shared with several programs across campus. We have about 27 students who have completed the informed consent and been enrolled, but I'm always looking for more, and there is money involved for them to participate. A majority of students right now who are currently enrolled are KU students, so we're hoping to build up those numbers from Notre Dame and Florida. But we're hoping to see if there's any differences across institution or territory too, knowing one's in the South, one's in the Midwest, and one's in a private institution. So, with that, any questions?
Did you say you have enough students from KU?
I have a lot of students from KU, but I could always use more, because what's happening is students, I think, are eager to enroll, and then they see the prompt and they don't complete it right now is what I'm having. So I'm gonna send my reminder emails and all that, but until they submit their essay, I can't pay them, and I want to pay them. Okay, perfect, thank you.
You're just using one prompt?
One prompt for all students, and it's regarding whether or not they should engage in providing health care for people who are currently here undocumented, and what that looks like, which at the time, ICE raids were not as prevalent, so I think there's more of maybe a social sensitivity to it than previously when this was developed. That could be part of it.
Do you have reason to suspect that any differences or effects you might see would vary with the prompt or type of prompt? I'm not super familiar with the field, but...
Meaning as in how they're inputting it into AI versus how they're responding to it individually, or?
Yeah, like any differences you might see, could they be prompt specific? I guess, could they vary based on?
It could. I think we tried to pick something that did both, had a potentially racial charge to it, but also something that as future health providers are specifically saying that they are combating in terms of health equity. But I don't know if they're going to be different. And also part of it is I think it's going to be interesting how a student interprets the prompt and puts it into AI to have it respond. Part of the study is not only are we asking them to submit their essays, but we want them to submit a screen recording of their submission so that we can see kind of their thought process. We played with the idea of cognitive interviews where we could be there with them saying like, why are you choosing to use that word instead of this word when you're putting this in? But that was just logistically really challenging to do.
Thanks.
Yeah, Doug.
What are your thoughts on using AI to engage in the research, like analyze the interviews you had or the...
Yeah, so we've actually done a study. We had one study, well, it came up with 2 papers where we did a thematic analysis across a bunch of student responses. We had, I think, like 42, and this was done a couple years ago, and then we ran the same data set through AI to see what its differences were, and there were some pretty significant differences in how they quantified things and showed significance, but also what it considered to be as a future impact to learning related to global health. And so we have actually done some studies to see if there's a differentiation between how it's interpreting students' responses compared to ours. Yeah. So, I mean, like, I think that lens of there always needs to be a human checkpoint is really important, but then I think we see in terms of like healthcare, AI is being used, and there's studies that show a doctor to check the credibility almost takes twice as long as it would have been if a doctor had just gotten to engage in the patient interaction to start. So is it worth the time or not?
And how do you, another question is totally different, but how do you deal with the biases that exist in humans? You're talking about the biases in AI, but there's biases in...
Yeah, I will tell you between Susan and my curriculum, this is something that we talk about at length and nauseum throughout our program experience. We can never 100% attend to human bias, but we do try to promote awareness of implicit biases, teaching students about intersectionality, having them engage with diverse groups of people to get alternative perspectives, engage with storytelling as a form of valid data. So I do think we do a lot of effort in that. I think what's challenging is not all disciplines are getting the training to acknowledge and be aware of biases, especially those that are largely at the back end of coding these models. They probably aren't having these conversations in their curriculum. And so trying to promote interdisciplinary discussions of AI, I think, is step one to acknowledging those biases, because they're never going to truly go away. Yeah.
I understand it's ongoing study, but do you think the result, once you found out, can you apply to the different discipline? For example, not only student pre-health, student learning, like in sport management or in exercise science, would that result would be applied differently?
Oh, I'm sure. I think obviously the prompt, if I was to say, could probably be a little different, just because I think I know very little about sport management, but I have a feeling that gender is a big kind of separating point among sports, and I mean, we know in terms of investment of teams and attendance and things like that. I'm sure that some of these concepts could be pulled over into other professions in terms of how we may be perpetuating stereotypes that are harmful for various groups' advancement in their respective fields.
Another follow-up question. According to your understanding, comparing the 10 public schools, 10 private schools, how do you think about KU?
No, I think we, as a university, have not been given very clear guidance on which direction to take, and I think we have two very different camps on where people want to go. I think that the Center for Teaching Excellence has embraced and encouraged people to use it responsibly and innovatively, which is really great, but I think others are warning against it because of fear of academic misconduct and things like that, which is representative of the entire field. I think a lot of people have two camps and they don't know where to go. I was surprised by how different private versus public were. Something that I did not mention was UNC Chapel Hill actually does not even have a policy at all, and they were the only one not to have a policy in that sampled 20 group. So I think we are in the midst of the majority of not knowing which direction to go yet. I think these top universities have a pressure to be trailblazers in how we should be going, knowing that they have big names and big reputations based off those rankings.
Thank you.
Yes, Bowman.
So what was the major responses when students got exposed to the virtual reality, the learning setting? And I'm just wondering, what was the positive things that you noticed it when they got exposed in the virtual setting?
Yeah, they were excited, overwhelmingly excited. Students thought it was, I think just the novelty of it being really neat and cool was part of it. And also Liz, who's my colleague, says that everywhere around Ethiopia and in chat smells like burnt popcorn. So she sat there with burnt popcorn like around the room to simulate while they're doing the virtual reality. And so they said that that was truly an immersive experience, which I think got them also excited for their upcoming summer capstone. Something that was a negative feedback, though, is they wanted longer, and part of that was just us not knowing virtual reality very well, and we leaned on ND Learning's experience, and they said some folks get really nauseous and dizzy from virtual reality after about 5 minutes. Students wanted longer, and so we've been toggling with that time just to see how do we engage in an immersive experience within a time crunch that also maintains people's wellness while doing it. So students enjoyed it, they gave us some feedback, and we're continuing to work with that. Did you have a question, Mike?
I did. In your study one, with the themes that you developed, how did you differentiate between ethical considerations and safety and privacy concerns? Feels like a lot of those responses might be similar.
And I will say some of them were, but ethical considerations were more at the human and person level, so things like integrity, fairness, and academic conduct, so how students or faculty should be behaving with this interface and with each other versus you said safety and privacy concerns is the other one, right? They were talking more so about data breaches and enforcement. And I actually have, I have the theme definition on here so that I could read it. Okay, so this theme is defined as the measurable risk or incidents where AI systems compromise user security, data confidentiality, or personal information, including unauthorized data access, misuse of sensitive information, unsafe outputs, and failures to comply with established data protections. So more of like a direct adversary to IRB type of thing, like how are we maybe not upholding that?
I suppose there was a cheating or misuse of.
Ethical considerations was part of that, but I will say in terms of academic misconduct, I don't think that's people's primary concern. I think that was maybe people's knee-jerk reaction concern to AI, but I think that has since been suppressed, seeing that there maybe is some bigger impacts related to AI use in terms of integrity than just cheating on an essay. Great. Well, thank you so much.
I've seen that study, was it 2.3, about there's no difference in cheating before AI.
Yeah, I found a study that said if a student was going to cheat before, they were going to cheat with AI. Like it's just a different mechanism for them to cheat. Yeah, but cheating has not necessarily gone up or down.
Yeah, but more effective.
Cheating happens, so yeah, new method for us to combat. So, well, thank you all for your time. Appreciate it.
Okay, all right. Good afternoon, everybody. I hope everybody's had some lunch because I'm going to be talking about food over the next 20 minutes. I'm really excited to share a little bit about the research that I've been doing over the past few months with our Food is Medicine program across Kansas. First, before I get started, I want to introduce you to a couple of people that we've gotten to meet. I want you to meet Fred. Fred is a fifth-generation farmer. He lives out in western Kansas. His office is his tractor. He developed diabetes in his 50s. And if you know most farmers, or if you have ever farmed, you know that farming, you don't eat your 3 square meals a day. You are typically like a binge eater. You eat when you can because you're working the fields. Farming is 365 days a year, 16-hour days. It's long hours. So a lot of times what goes into their bodies is food that's just meant to sustain them through the day versus food that's healthy. So as a result of being diagnosed with diabetes, he developed some issues, neuropathy, he gained some weight, high blood pressure, really felt crappy, where he got to the point where his very own livelihood was compromised and he could no longer climb into his office anymore. When you experience something like that, there's just a lot of emotional, mental, physical problems that occur from that. So Fred was really stuck in a rut. Now I want to introduce you to Maria. Maria is a caretaker. She's a Hispanic woman. She has a very large family. Her pride and joy in life are her grandchildren, just her family in general. She cooks and has all the get-togethers in her family. And one of her primary things that she does is that she helps out her children by picking up the grandkids after school, gets them to other activities. Maria was also diagnosed with diabetes along with her husband. And as a result of that, started having some poor vision issues, and some very swollen feet. They were so swollen that she could not put shoes on, which when you can't put shoes on and you lack the ability to be able to properly see, that creates some problems with going to pick up your grandchildren from school, go on walks with them, just be active, just quality day-to-day life things. So the diabetes absolutely impacted her quality of life as well, along with some of the relationships with her children. So now let's bring in what are Food is Medicine interventions. Most everybody here has probably heard of what Food is Medicine is. It's a pretty sexy term, and it has been for the last few years. When we think of food as medicine, there's a whole lot of different definitions out there. For example, if you ask a food bank what their definition of food as medicine is, they would say, well, we think any food is medicine because we are providing nourishment to people who can't have it. However, when we look at like a medically tailored definition, we're really looking at like 3 broad concepts here: produce prescriptions, medically tailored groceries, and medically tailored meals, with medically tailored meals being like that highest level. So if you were to look at like an inverted pyramid, they would represent that highest level. So they're really treating the disease. So a lot of times you think of it as it is a prescription, but instead of a prescription for drugs, it's a prescription for food. Big picture nationally, as I said, food is medicine. It's a hot button issue. It's a very sexy term right now. It has been for a few years. If you just look at like PubMed data that's been published, we've seen a huge spike in it, as well as just Google search results as well. To get a handle on this, the Aspen Institute has come out with 2 reports, with a 3rd one coming out this year as well. So these have been released every couple of years. And the goal of their work is really twofold. One is to provide an evidence base of what is happening on a national scope with food as medicine programs, but also secondly, to identify some of those gaps and future directions that we need to think about as we continue with these food as medicine programs. What we do know from these reports is that food as medicine programs have seen positive outcomes. It does increase food security status. A lot of times food as medicine programs, and I'm going to call them FIM from now on, just to shorten my language a little bit here. It's not only tailored for people with diet-related chronic conditions, but also those who score very low or identify as having very low food security or low food security as well, as a way, because they typically are more likely to have diet-related chronic conditions, but also are more likely to lack that access and affordability to be able to buy the foods that they need to treat their disease. So what we do know from the evidence that's out there right there, that people are experiencing better health outcomes, that there is improvement in just like the quality of care, so lower hospital readmission rates, also lower emergency room care visits, and as a result of that, lower costs, overall healthcare costs, and deprescribing some of those prescription drugs as well. So there's those economic benefits. What we're also seeing, which I was kind of a surprise nationally, is that there is an increase in provider satisfaction and just relationship building between providers and their patients as well. However, the gaps that have been identified is we really don't know a lot about what's the proper dose of food. It's much harder to like target dosage for food versus prescription drugs for food. So that's a huge gap right there, as well as like the frequency, how often they should be eating certain foods, how long these programs should be in advance. Ideally, they should be lifetime, right? But these run in like intervention periods as well. So 3 months, 6 months, maybe year-long cohorts. And then the baseline of patient health as an effect modifier. We know, especially from our work in Kansas, that where you start, like with your A1C levels, the higher your A1C level is, obviously, if you follow these programs, the more likely you are to experience change. Whereas if you're at that lower A1C level, at that pre-diabetic range, that change is minimal there. And we have a big gap in just like understanding like the clinical capacity and those clinical roles as well. So another huge gap is trying to understand, well, what's happening in certain geographic regions. When we look at food as medicine programs, for the most part, we look at programs that are on the East Coast and the West Coast. Okay, so that's where most of our publications have come from. That's where most of the research is. When you look at those Aspen Institute reports, we're looking at places like Boston, Portland, Oregon, Seattle, Washington, San Diego, California. There is a real gap in understanding, well, what's going on across the plains in the Midwest? So the purpose of what we are trying to do in Kansas is to understand, what does food as medicine programs look like when you take Sheridan County, Kansas, which is situated out in northwest Kansas. It is a designated frontier geographic region. If you don't know what that means that there are 6 people or less per square mile. So if you can imagine a rural frontier area like that, they also are experiencing a lot of gaps in care, gaps in healthcare, a lot of those social drivers of health that are really important to improve people like Fred's health. Access to food is minimal as well. So trying to get some of those like systematic or systemic issues to places like Sheridan County, Kansas, that creates a lot more challenges versus some of our urban communities like Boston Medical Center, or even when we look at like Wichita. So our goal is to really understand what does it take to look like when we're looking at predominantly rural and frontier settings. So let me give you a little bit of context behind Kansas. If you don't already know, we are a huge agricultural state. We are known as the breadbasket of the world. We are the leading producers in both wheat and sorghum. And our cattle industry, our beef industry, is also usually second or third in the nation as well, as far as number of cattle across Kansas, the number of heads, as well as beef production. So we have beef processing industries that are located in southwest Kansas as well. Our demographics overall, we have increasing aging population, but also increasing in diversity. We have rising rates of diet-related chronic diseases. When you look at Kansas overall, and I'll show you a map here in just a few seconds. I keep track of time, I'm already running way behind. When you look at a map of Kansas overall, we are 98% designated rural. However, only about 30% of our population resides in those rural areas. But we are largely a rural geographic region. When we think about that rural geographic region, there's a lot of disparities that are happening in those rural geographic regions. We are typically one of the top 3 to 5 most, depends on what year you look at, considered one of the most rural states in America. And that's just based on that distribution of our population as well. Because of our agricultural context, there is need for the migrant workers to be able to farm the fields and work in the meat processing, meat packing industry. So that's where we see that increasing diversity. As I mentioned, we do have rising rates of diet-related chronic diseases. We have 60% of our population experiences food insecurity. However, they do not qualify for some of those food safety net programs, which creates even more of a gap and a disadvantage as well. So what are we trying to accomplish with our study? This is not an opportunity for us to like compare conditions. Right now, it's what we call like just trying to understand the feasibility of what it looks like to pick up food as medicine programs and put them in diverse geographic regions across our county. We also want to understand, what do patients and providers think about these programs? Does it make a difference? As well as collecting some of that outcome data, and just trying to distinguish a little bit more about who is food as medicine working best for. Here's a timeline. So this project has been funded by Sunflower Foundation. They've really been pioneers in understanding what food as medicine looks like in our state. They actually started this work pre-pandemic, and then the pandemic hit, and so that put a stall out. So starting in 2021, they really hit the ground running with trying to understand, well, what would food as medicine look like in Kansas? And then reaching out to some people to understand what would it take, what were some partnerships that were needed, and then identifying federally qualified health centers across Kansas that could also feasibly take part in this initiative as well. One thing that was really important with this initiative was to have a 6-month planning phase. It's a lot different to implement and provide prescriptions for food than it is drugs, and so there was a necessary need to understand, how do we get food to places like Hoxie, Kansas, or Dodge City, Kansas, when they can only get food deliveries from a food bank maybe once a month. So trying to understand what were some of those things that we need to overcome. Here's our map. So we have 6 clinics across the state that are participating in it. So there's where Fred is from. Here's where Maria is from, Dodge City, Kansas. You can see the orange on this map. The more orange it is, the more rural that county is. So you can see where we are like just a hugely rural state, whereas the purple spots, that represents our more urban areas. So we have 2 urban areas. Lawrence is one of them, Wichita, and then the rest of them are, so we have 3 rural county clinics, and then Hoxie is our one designated frontier clinic as well. So we're really trying to understand, what does it look like for food as medicine programs to take place in very diverse geographic regions across our state. This is a lot to take in here. But what I want you to focus on is, so you can see our target population, for the most part for both cohorts, was pre-diabetes, diabetes, poorly controlled diabetes. It changed a little bit in phase 2, but not much. The type and frequency of the food assistance, you can see where like Wichita, which was one of our urban areas, they could get weekly deliveries from the food bank. So Kansas Food Bank and Harvesters were 2 main players in this, and the reason why we chose the charitable food system to provide the food was because it just makes sense, since so many of our participants are food insecure. Once they're released from the program, most likely they're going to continue getting their food from those food banks or food pantries. So it makes sense to include them in these initiatives as well. The problem is trying to, these are 2 very siloed systems. How do you combine healthcare with food provisions as well? So some of our clinics were able to get weekly food distributions, whereas some of our clinics, it's once a month. So again, that points back to like that dose, duration, and frequency of food, and trying to understand how much is needed really to make a difference. You can also see like nutrition education. A lot of it depended on the capacity of the clinics. When we look at our rural areas, there's a huge dietitian shortage. And so that's like a primary component of these programs, but there was a lot of reliance on the community health worker force. And then you can also see like each clinic also distinguished how long they wanted their program to go. Most of them said 3 months, but we had a couple of clinics that also said, you know, we think it takes longer for lifestyle changes to occur, so we want this to happen for a year. So a lot of variability here, which kind of makes our analysis crazy as well. But we wanted to leave this up to the clinics. So what did we measure? As part of our quantitative evaluation, our clinical outcomes obviously were A1C levels, since we were looking at diabetics, body mass index, and we also collected blood pressure data. And then we had participants complete a pre-post survey that just measured food security status, daily self-reports or weekly self-reports of fruit and vegetable intake. We did a depression scale and also quality of life indicators, and then psychosocial and behavioral components as well, self-efficacy, their readiness to eat fruit and vegetable scale, eat produce items, and cooking frequency as well. Here's like just really a quick snapshot of our baseline characteristics. So there have been 2 phases of this. We're still cleaning up the data, but you can just kind of see like a description of our sample here. Most of them were diagnosed with type 2 diabetes. It did change it in phase 2 with a couple of our clinics identifying other populations that they wanted to focus on as well. But along with those type 2 diabetes, oftentimes they are suffering from more than one diet-related chronic condition. So you can see a lot of them also had hypertension. 2/3 of them, roughly 2/3, did identify as having low or very low food security status. And then we had a lot of depressed patients as well, and those that were living below the poverty line. So you can see when you combine that with that, trying to eat healthy is really difficult, and so that just compounds those issues even more. So what did we see as a result of these programs? We did see some significant values as far as patients that were improving in their A1C levels across both phases. If you see like an asterisk up there, that's where we saw the most significant differences. So average A1C in both phases did significantly decrease. We also saw decreases in blood pressure as a result of the program. Not much change in BMI. But again, with some of our programs only being 12 weeks long, that's probably not something we would expect to see much of a change in, but I think we were wanting to see a little bit more change there. We also saw, as a result of those changes in some of those cardiometabolic outcomes, of like what was maybe pushing those changes. And so there was a significant increase in the servings of fruits and vegetables. We see increases in fiber and then significant increases in some of those micronutrients as well. This was a huge one, the reduction of just sugar sweetened beverages, especially our Hispanic participants down in Dodge City, Kansas. They were drinking so many servings of soda a day that just that simple switch to water or unsweetened beverages made a huge change in just about everything for them. And then self-reported diet quality also, we saw improvements there. As far as depression, we saw more changes in phase 2 with most of these mental and behavioral health outcomes as well. Some of the more prominent ones, just like the frequency of cooking at home, because now they had the ingredients. Some of the clinics were recognizing just through a social drivers of health survey that they were doing, that realizing some homes, one of our clinics was in Pittsburgh, Kansas, so Southeast, there's a lot of generational poverty going on there. And so just realizing that some of those households just didn't have kitchen equipment. So providing some of those just basic necessities really helped to improve like what they were doing at home. Here's like a snapshot. When we first looked at these, we were like, oh God, look at all that red there. But some things that are important to remember here is that anytime we're talking about like lifestyle changes, it takes longer than 3 months. Plus, we did see a shift where there were more improvements in phase 2 just as a result of adjustments in these clinics from phase 1 to phase 2. And being able to improve in some of those results as well. That clinic A up there, they changed and modified so much that it was just difficult to see any changes there. But the population that they were focusing on, it was also kind of understandable as well. However, we did see areas where we didn't see a whole lot of improvements, or there were certain factors that maybe impeded change. So we noticed that like a big one is their self-rated health. If they were single, had low health literacy, were missing 2+ appliances, we just didn't see much changes there. There was also those differences in like how they identified food security status as well. And so this is where we really emphasized how clinics, when they start to screen people for these programs, it's really important to understand some of those social drivers of health, just to see what needs should be met before they're enrolled in these programs as well. I know I'm really running out of time here, so I'll kind of skip through this. We'll get to, so one thing that I do want to highlight is how important like our food banks were in this work. Again, we're looking at 2 siloed systems here, but they have similar missions, right? Food banks and healthcare entities exist to improve the health and meet the needs of their community, but yet they're very siloed. The adaptability of the food banks of just wanting to partake in these programs was phenomenal and really a crucial part of the programs across Kansas as well. However, the issue lies in some of those systemic issues. How do you get food to people across Western Kansas on a more regular basis when right now, like where Kansas Food Bank is, they're located in Wichita, Kansas. So trying to get food more regularly to Hoxie, Kansas, that takes resources, that takes money, that takes capacity. So trying to problem solve some of those issues has been one of the probably biggest challenges. Food as medicine, it's not like putting a pharmacy in a clinic, right? So with food as medicine programs, they're much more holistic. It goes beyond just providing food. There's also nutrition, education, community health worker support, regular provider visits as well. So if you look down at that lower right-hand picture right there, that is our clinic in Newton, Kansas. Clinics they're not set up to have culinary medicine or kitchens, and a huge part of these programs is skill building and doing some of those cooking and then learning together. So one of the community partners they relied on was a local high school for a home economics classroom. Hoxie, Kansas could get deliveries once a month on food. So they have the Elephant. That is a restaurant that they contracted with because the Elephant, being food service industry, can get regular food deliveries in from Sodexo or whatever they're using. So they were able to build pretty much like medically tailored meals for the patients that were enrolled in the program as well. Now, here's like the caveat to that. The Elephant, which is a phenomenal restaurant, been there several times myself, they closed down because they're in a rural area. And it wasn't that they didn't have business, it was because they couldn't have the proper workforce. So lots of problems there. Fred, so let's just revisit Fred real quick. He went through the program for 1 year. He lost some weight. He learned mindful eating. He really bulked up on his fruit and vegetable intake, reduced his A1C by quite a bit. He was like at 13.1, so he felt miserable and was able to get it more like to a pre-diabetic level there. So he was able to crawl back in his tractor. Maria also, she lost some weight, improved her blood pressure and A1C levels, able to take short walks, baby steps with her granddaughter, and was able to also see better as well. So we're learning a lot of lessons. I could talk about it all day, but gaps that we know that we need to consider is like, how do we solve some of these more systemic issues? Dosing, we also, the dosing, we need to capture like what should that dosing and frequency be for these types of programs as well as bulking up like our community health worker industry. One of the big things we learned was how important that contact person is at each of these clinics, because that's that relationship and kind of that moderator between our patient and our provider. But we did see like improvements in just like patient providers as well as providers learning to understand to look beyond like A1C numbers and really talking and listening to their patients about, my A1C maybe hasn't dropped, but I feel better, I'm walking, I'm getting out and exercising, I don't feel as depressed. That change takes time for those A1C levels and sometimes blood pressure and weight to drop. So that was a lot, and I didn't get through everything I wanted to. Any questions since I ran over? Yes, Joe.
Do you track GLP-1?
No. You know what? That is something that has been a huge discussion among our group. We did not, and so that is something that we need to consider for the next one. We tracked medication use. So as far as we're seeing, people weren't putting anything about GLPs in that medication list. So no, we did not. We did not explicitly. We tracked more like if they were on, some of their diabetes medication as well, but GLP was not something that was specifically tracked.
So they were recruited through the clinics?
They were recruited through the clinics. They were identified based on criteria for being pre-diabetic, diabetic, or at risk for diabetes, yeah.
So were these people that were already going to the clinic, or
these
did
were,
they start getting more clinic visits because they were enrolled in the program?
So they were typically identified through their primary care provider, usually, or a provider, as being somebody that would meet the criteria for the study, for the program. So they were already enrolled at the clinic.
I was thinking, like your two anecdotes, these people had horribly uncontrolled diabetes.
Yes,
right?
yeah.
So, how much is this, they're eating more fruits versus they're actually getting their meds squared away and complying?
So, you bring up an interesting point, and one of the analyses we are doing, we're actually using like the trans-theoretical model to look at like the pre-contemplation to like the maintenance stages. And clinics did have to adjust from phase 1 to phase 2 because they may have identified people who had the most poorly controlled diabetes that really needed this program, but sometimes they were like the least compliant as well. So clinics in Yeah, right? So that second cohort, some of the clinics set criteria of like, if you're missing your appointments so frequently, then you're gonna obviously not take part in these like bi-weekly or monthly nutrition education sessions. And so we're gonna put you on a wait list until you become more compliant. And we're gonna move people into these programs that generally are more compliant and want to be in these programs, are actually going to succeed and carry
But they're
through.
effectively getting free food that they weren't getting before, right?
Yes.
In the program.
Yes, they are. Yeah, they were getting produce and also shelf-stable diabetic-friendly foods, which, yeah, we're.
I just wonder if the intervention is really, we're
Is
gonna
it
give you
the
free food, but you have to come in and see the doctor and get your meds squared away.
So that's like one of those confounders. It's like one of those things we need to look at more. We did collect information on like the dose of the medications that they were on. That's not something we asked, like how compliant were they with medication adherence. But one of the things that we do know from food as medicine programs is there is usually a reduction in deprescribing, but also an increase in medication adherence too. So it goes hand in hand, but the food is certainly, your diet certainly, we're seeing that as like, that's that number one indicator for like overall good health, right? Or for physical health is diet, what you eat. And so did they report, we couldn't track like the food by observing, we just did self-report. Were they eating the food? They were eating the produce, not so much the shelf-stable items, because it was like oats and whole wheat pasta, and not necessarily culturally appropriate for like our folks down in Dodge City, Kansas. But medication adherence, I'm sure, is part of it. But the food is also part of it as well, because we did see increases in fruit and vegetable consumption as well, where some of them weren't eating it at all, now they were.
In your table that had the A1C data, it was like minus 1.3. Is that 1.3 percentage points or 1.3%?
1.3%. So A1C is like a percent.
Yeah, okay, but it's actually so their score for A1C went down by 1.3.
Yes, yeah, yeah. Right, yeah, I should clarify that. Any other questions? Okay, thanks guys.